The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we are thrilled to have Dr. Schuerer here to review the management of all things abdominal trauma. Dr. Schuerer is a trauma and acute care surgeon at Washington University in St. Louis.
Thanks for having me. It's great to be here. Always like to discuss abdominal trauma, something we deal with a lot.
And my name is Kerry Swanson, and I am a general surgery resident and will be your host for this episode. The abdominal cavity extends from the diaphragm to the pelvic floor, and within that space lies many organs and vessels that, when injured, may be life-threatening. Abdominal trauma presents with a wide range of injury patterns that we must be able to quickly recognize and treat as part of the larger trauma evaluation. We separate the mechanism into two buckets, penetrating and blunt trauma. Let's dive right into a case scenario to guide our discussion. A 27-year-old male is coming to your ED as a level 1 trauma with a gunshot wound to the abdomen. You're told that per EMS his heart rate is in the 110s with a blood pressure of 105/60. What are you thinking about as you wait for this patient to arrive?
Well, this is obviously a penetrating gunshot wound, but we always are getting notice out there, and we are trying to understand the mechanism because it's pretty important in our understanding of what's going on. It's also important to know if there's gunshot wounds to other areas, just like if you're a blunt trauma, how you were injured, whether there's potential of a lot of injuries or less. This one says a gunshot wound to the abdomen, which usually confines us to the area around there. However, as we know, bullets can be contiguous to the abdomen and also hit the chest, pelvis, and upper extremity and lower extremity as well.
So how do you want to prepare for this patient's arrival, and what do you want to communicate to the team in the trauma bay?
Well, clearly people have to be ready as usual with their PPE, making sure in someone like this, it's likely that they're going to need some acute intervention and potentially an OR, and have the OR there and ready. And we do have blood available in our OR, but that's something you might want to get ready if it's not readily available for you. Certainly, we think about all the injuries in the abdomen that could occur. The liver and the spleen will bleed the most, but certainly large vessel injuries as well. Kidney is in the posterior portion of the abdomen, and of course, the small and large bowel make a large part of the abdomen, so all of those could be injured. Depending on the stability, we kind of get an inkling of where it is, the trajectory of the bullet wound, but we're going to be ready to give this person blood. We're going to get ready to assess them quickly and make sure that we're ready to take care of any of those things as they arise.
So you mentioned giving blood. What are your thoughts on crystalloid, colloid, and hypertonic saline in the trauma patient?
Well, in general, we are trying to get away from giving a lot of crystalloid. Although I think we've gotten so far that it's okay still to give a little bit of crystalloid as we figure things out. But clearly, if people are hypotensive and tachycardic, blood is better. And in our case, we use whole blood for a massive transfusion protocol. And if you don't have whole blood, we use component therapy. And the idea is to try and match it closely to what they're bleeding, which is straight blood. We should not give too much crystalloid. That can certainly hurt someone and thin out their blood basically and make it easier for them to bleed. We've learned that from a lot of trials, so we understand that large amounts of crystalloid is bad. We occasionally will use hypertonic saline in people with head injuries, but in general, it's not something we would use in an initial resuscitation for a bleeding patient.
All right, so back to our case. He arrives to the trauma bay. He is tachycardic now to the 120s with systolic blood pressures 80s/50s. As with any trauma, we begin with the primary survey. His airway is intact, he has bilateral breath sounds, and he has intact femoral and distal pulses. His pelvis is stable and his GCS is 15. On secondary survey, we note that he has 3 gunshot wounds, 1 in the right upper quadrant, 1 near the umbilicus, and 1 near the left flank. His abdomen is tender, but he's not peritonitic. Would you like imaging on this patient?
He's certainly going to need that. I mean, as you're looking at him, I'm just going to add his blood pressure a little lower than we originally thought. This is someone we're certainly going to think about getting blood to, as that pressure is less than 90. And given the vitals there would probably be an MTP. But his pressure is not that bad that we have to think of other things as well. But certainly the first thing we would do is listen and get a chest x-ray. We want to specifically see if there's any pneumothorax that could be leading to this, or if any of the bullet wounds have gone across the chest as well. he's really not going to be peritonitic early on, but tenderness is a sign. And this guy could go to the OR for an operation. Sometimes we look at that and the stability. He's a little on the low blood pressure side. If it's a little higher, we think about CT scan. Scanning's difficult in penetrating injury sometimes. We're trying to understand a trajectory. If there's multiple gunshot wounds and multiple cavities, sometimes a CT scan can help us figure out where to go. If we're significantly concerned about hypotension being due to a spinal cord injury, we can get that too. But again, if they really are, if they do have a low blood pressure, we're leaning much more towards the OR than going to a scanner. We're lucky in our center. We have a CT scanner right around the corner. Many don't, and it is not a good place to resuscitate a patient in a scanner. They should be in the operating room if they have any inkling of being unstable.
Okay, so you mentioned CT scan. What about the role of FAST for this patient?
Well, FAST is certainly better known in blunt trauma, has been shown, but we do know that if we are able to see blood and they are hypotensive, it really is helpful as a marker the person needs to go to the operating room and probably needs an MTP. The problem with FAST is not specific as what's injured, and sometimes, again, in penetrating injury with retroperitoneal injuries, you won't see that. Also with blunt. So it really is helpful when it's positive, and if the patient's hypotensive, it really guides your resuscitation towards being in the OR.
So as you mentioned earlier, your plan would be to take this patient to the operating room for a laparotomy. Before we talk about the trauma laparotomy, let's quickly review the management of some abdominal injuries that could be managed non-operatively. First, what patients qualify for non-operative management?
Well, when we're mostly considering solid organ injuries, and again, blunt or penetrating, but certainly much more common in blunt injury. We've found over time that especially liver and spleen injuries, if they're not too bad, will not need an exploration, and we have other adjuncts to help treat those patients. When we say non-operatively, sometimes interventional radiology can be utilized. In penetrating injury, the list is obviously much smaller because there's such a high risk of bowel injury, but we have seen a significant ability to treat liver injuries that are single and penetrating and obviously not involving bowel. Those can also be treated non-operatively.
So the spleen is one of the most commonly injured solid organs and has a very specific management pattern. How would you approach it?
Well, I think there's been more papers written about the spleen than anything else and how to approach that overall. Clearly, the unstable patient with a major grade 4 or 5 or unstable at all should belong in the OR and have a splenectomy. We have learned a lot about splenic salvage over time, though. It started a lot with pediatric literature, and we've moved to adult. And in these cases, we can use adjuncts like interventional radiology to help us. It's interesting, as we've learned this and we think we're saving more spleens, sometimes it seems that we're taking all the spleen grades together and trying to gauge how to do it. The fact is most 1 and 2 grade spleens don't need much. They probably will never need interventional radiology or very unlikely. Grades 3 may be ones that you look for blushes to see if there's something to embolize. And certainly if there's a stable 4 or 5, you're definitely going to consider IR and see if you can at least reduce the blushes there and by embolization of some sort. Problem is we find that a lot of those on 4 and 5 spleens come out later anyhow because of pain or necrosis or other things. I think we're still learning a lot about this, but we surely should take and look each of these spleen grades individually as opposed to trying to take them as a bunch. Knowing in general, less injured most likely can be treated non-operatively, and higher ones, if stable, with interventional radiology.
And if we do take out the spleen in somebody, what's an important thing that needs to happen to these patients?
They certainly are at a higher risk of certain bacterial infections and need to make sure you cover all of those, often on their way out. But if you have good follow-up, it's best to get them several weeks later.
And we're specifically talking about the splenectomy vaccinations for encapsulated organisms.
Absolutely.
And if this patient was hypotensive, the plan would obviously be to go to the operating room regardless, correct?
If the patient's hypotensive, they're going to need to go to the operating room. The trajectory here is leading towards that, and with multiple injuries, it's hard to exclude a bowel injury as well.
Now, in a separate vein of thinking, what about if this was a pregnant patient?
Well, the pregnant patient has to be treated as if they aren't pregnant initially because you have to treat the mom. You have to make sure the mom's alive for the baby to be alive as well. So we do many of the same tests. We don't worry as much about radiology when it's needed because if the mom becomes unstable, the baby will be even more unstable. Pregnant women will actually use that blood, and then the blood becomes restricted to the fetus. So trying to get the mom resuscitated is most important.
following the dictum of the best way to take care of the fetus is to take care of the mother. All right, let's get back to our original case and go to the operating room. So you've made it to the operating room. How would you like to prepare this patient?
Well, the operating room has to be ready. You know, we have a trauma bay all the time, and most of the equipment is there and ready to be opened and quickly counted as you're bringing the patient upstairs. And it's really important the team is ready for that. We usually like to keep the arms out. Anesthesia can have access that way if needed, especially for further IVs or art lines or the like. Clearly, we like NGs and Foleys. We try to avoid OGs in general unless there's head injury, because often these people have valve resection. They're going to need that after the operation. We do prep and drape, usually all the way up to the sternum and all the way down to the thighs. Somewhat that's modifiable depending on where the bullet is, but we want to make sure we have access to the groins, access for vein if needed for reconstruction, and also quick access to the heart and chest if needed. We do use one dose of broad-spectrum antibiotics, and usually we don't need to redose that unless we end up with a blood loss of the patient losing a whole volume of blood loss, and then we would usually need to redose it. If they have contamination just at that time with no long-term contamination, that is the only dose of antibiotics they need for prophylaxis.
All right, so once you prepared, how do you approach the operation?
Well, we do ours with a midline incision. It's no time to get cute with different types of incisions at that time. Probably when they're unstable, certainly not trying to be cute with laparoscopy either. So we want to do a large midline incision. We want to make sure you get in quickly and then quickly pack all 4 quadrants. That also can be a little bit modified depending on where the blood is and where the bullet is, but clearly you want to make sure that you're controlling the hemorrhage, letting anesthesia catch up as much as possible. We really see that a lot with spleen and liver. If you can pack that area, let anesthesia catch up and get the blood pressure coming back up.
So once you've finished packing, how do you approach where to start unpacking?
Well, that's systematic. And, you know, if you have packed away from the gunshot wound, you usually want to start over there, make sure you don't have any blood welling up in something that's unexpected. So usually you'd start there, and then you go towards the area of injury.
So there are obviously a multitude of injuries that can occur in the abdominal cavity, but we'll only go through a few here. So as you're unpacking, you find a liver laceration with active bleeding from the parenchyma. How do you approach this?
Well, there's a lot of ways to approach the liver injury, and depending how bad it is. The good thing about liver parenchyma in general, it's quite forgiving. So usually packing is a first choice. Sometimes we will pack with a hemostatic agent if it's not that bad of a laceration, and just use that. And time often does quite well. Again, as we've learned for non-operative treatment of liver as well. We have some other ways to exclude the inflow. Pringle maneuver is a classic one where you can try and decrease most of the inflow. Trying to do bigger operations on the liver is hard when they're actively bleeding, like total vascular isolation or even a atrial cable or shock shunt. They can be done, but if you're going to do that, you got to recognize your injury early and start that quickly while someone's holding pressure. If you try and start it late when they've already bled a lot, you'll never have a success because they just get very cold and coagulopathic quickly. The liver can really bleed a ton, especially if you're in a hepatic vein or an posterior IVC. We do a lot of topicals once we've gotten the main vessels controlled, and topicals are pretty effective on the liver or the spleen, although general if the spleen's bleeding, we will take it.
All right, so moving on, now you've addressed the liver injury for now, and you now find multiple small bowel enterotomies. You find 4. How do you approach this?
You know, you have to see how far apart they are in deciding how much bowel you're going to resect. I would add as you're going in, part of controlling things is controlling that bleeding. So maybe while you packed the liver the first time and didn't have definitive control, you at least put some clamp across these enterotomies to decrease the spillage during that time. It's one of the things you kind of have to decide which is the worst, but certainly stopping the major bleeding and stopping contamination are both high concerns of what you're working on. So what you do is you look at these small bowel injuries and see how far apart they are, and if they can be in 1 or 2 resections. It's probably not a good idea to do 4 separate anastomoses unless you're really trying to save a lot of bowel, because you tend to have a risk at that point of a leak at a later time.
And then when considering whether or not to anastomose the bowel at all, what do you consider?
Well, certainly how the patient's doing overall. If they've been hypotensive and on pressors, it's very likely they're going to have a damage control laparotomy anyhow, which we can get to a bit later. But if we're going to do that, for sure, we can leave that open. But again, you don't want to be creating an anastomosis in someone who's markedly hypotensive.
So moving on, You also find that there's a zone 1 retroperitoneal hematoma. Before we get into the details of how you might approach a hematoma, let's talk a little bit more about the different vascular zones of the abdomen and what important structures you worry about. So starting off, this is a zone 1. So what does that mean?
Zone 1 really means the central area of the abdomen, and clearly your biggest problem is the aorta and the IVC, and or the major branches of the aorta in that central zone. Flanks, really, you're mostly worried about the kidneys there and the large vessels going to and from the kidneys, and that's usually where you'll see those flank injuries. And zone 3 is the pelvis, and sometimes those could be worst at all because if the arteries dive down and are deep and can be hard to get to, especially in a male in terms of the way the anatomy is structured, and the veins are numerous posteriorly, and so it is something we try and stay out of when everyone else is doing surgery around the colon and the rectum. But in this case, it's something you have to try and control. So that's usually a pelvic hematoma. Depending on what's there, you have to know how to approach that, and whether it's blunt or penetrating also makes a difference.
Okay, so how do you handle this zone 1 hematoma?
Well, you're going to try and see which side it's coming from, even though we saw zone 1 at central. Sometimes it's more right, sometimes it's left. So you have to do a visceral rotation either to the left or the right to get to that. On the right side, you'd be taking down the colon, and the duodenum on the left side, you're lifting up the left colon and getting back over to the aorta, sometimes bringing the kidney on either side, depending on how deep you need to be. But those medial visceral rotations are something that's really important to know and know how to do quickly. One of the good things is when there's a big hematoma, the medial visceral rotation is quicker because it's already been done for you.
And if the injury were in zone 2, how might you manage it?
So zone 2, like I said, is likely kidney, and then you got to look at the mechanism. If it's not expanding and it's blunt for sure, most will leave it and the kidney will kind of heal itself. Maybe we'll need some other stenting or embolization in the future, but penetrating is a little bit debated. Since you have a hole through it, the hematoma isn't contained as much, and sometimes it's harder to leave a stable hematoma with a penetrating injury. I think that takes a clinical decision on what you think you're going to be doing, or maybe if you're doing a damage control, packing it and coming back. But if it's expanding, you kind of have to look at it, and you have to be prepared to cross the kidney, clamp across the kidney. I think we tend to take the kidney really quick when there's a chance to repair it a lot. So better to probably work not at getting proximal control initially, because that's hard to do if you don't do it a lot, but mobilizing the kidney up and then clamping across the whole hilum so that you can have that and at least give a chance at repairing the kidney.
And if the injury were zone 3, how might you manage it?
Well, again, blunt, hopefully you're not even in the OR for sometimes. But if you're there, pelvic packing is clearly there. If it looks arterial, you could try and isolate the internals proximally and ligate them to see if that slows it down. But there's still a lot of cross-lateral bleeding in the pelvis. So likely interventional radiology is going to be part of your treatment algorithm, depending, again, why it's injured, if it's penetrating versus blunt, and if there's one spot or multiple sites that are bleeding.
All right, so after exploring, you return to the right upper quadrant. The liver appears hemostatic. You've run the small bowel again, find no additional injuries, and you did an IVC repair, and that appears to be hemostatic. What do you want to do next?
Well, I said when we came in that you're always trying to make sure anesthesia is with you, making sure that if you've done something like controlled the IVC and there's some significant bleeding, that the anesthesia has time to catch up as you're doing that. So it is really good to make sure and see how the patient's doing. Again, mentioned on the way in, we use whole blood at the beginning, but then a resuscitation that is a 1-to-1-to-1 ratio has been proven to be beneficial and is something we should continue even after your first round of whole blood. The anesthesia needs to keep warm and keep doing those things to keep the patient in that state. If you can't get them there, sometimes it's time to stop, and that's when you do a damage control laparotomy, which you mentioned a little bit earlier. In this case, you're halting the operation and coming back, and what you want to do is get that person back to the ICU with some type of abdominal vac pack and get them resuscitated, get them warmed, maybe continue with a massive transfusion if they need it. But you really don't want a cold coagulopathic patient in the OR. They will, in general, just get sicker on you and bleed more. So it's better to make way up to the ICU and get them recovered.
All right, so he goes to the ICU postoperatively and does well. He returns to the operating room 48 hours later, where he remains hemostatic. His bowel looks well perfused, and he successfully anastomoses and closes abdomen. So in this scenario, we touched on damage control laparotomy. What is the evidence to support this approach?
Well, damage control laparotomy, I think, has made a major change to what we do in trauma. And luckily, it came about during my training as we started. And it was Mike Rotundo and his group at Wake wrote about it when he was a fellow. And the idea was the cessation. I don't know if many people obviously now would know this, but it used to be bad to not finish your operation and to leave them open. And that was something that was frowned upon quite significantly. So this was a major change in how we thought about things, and we have shown a huge improvement. Interestingly, with the resuscitation back then, it was also a lot more colloid, and so these people were much more swollen. As we've done a lot better with MTPs, especially with 1-to-1 ratios, we're able to get these people closed on the first take back as opposed to multiple times. So that's also changed since we've learned more about how to do damage control well.
Another important adjunct to the trauma is the FAST exam that we touched on earlier. Tell us more about some of the important landmark studies that have shown the utility of the FAST exam.
Well, Grace Rosicki was probably one of the better known folks who have talked about FAST, but it's certainly been added to over time. The FAST originally was just looking mostly around the bladder, heart, and around both kidneys to see if there was bleeding or in any of those quadrants. And it was very helpful when we see, and there's blood there, that it could be leading to hypotension and could be leading to solid organ injury. Again, mostly shown originally in blunt trauma. Now, though, with FAST, we're much more able to look at other things, and including looking for pneumothorax early. It's a one way to get it done even quicker than an X-ray. And so I think that is something that's helpful, and it's being used in the military too to, when you're in more austere environments, to be able to look at ultrasound to see if that's a problem. So clearly from what Dr. Rosicki's initial data was, we've been able to show it's much better across the board. And again, it is morphed into being used in penetrating injury and in the pregnant patient as well.
Thank you, Dr. Schuerer, so much for being with us today. We got through a ton of great information about abdominal trauma, but also recognize there is a lot more to this topic. As always, if you're looking to learn more, you can check out some of the literature we referenced in today's episode in the show notes, and a full review of abdominal trauma can be found in the Washington Manual of Surgery.
Yeah, it was great to be here, and I would emphasize there is a ton in this abdominal trauma chapter, and I think it's a good thing to look at. There's no way we could hit all of that in one small podcast.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.